Okay, let's go ahead and get started, everyone. Looks like we have a good group here where everyone could get up and introduce themselves individually. So, no, we're not really going to go around the room. I'll introduce myself. I'm Larry Slutsker from PATH, and I'm co-chairing this symposium, Malaria Pre-Elimination, Ensuring Correct Care of Reproductive Age Women. I'm honored to be here with my co-chair, Professor Clara Menendez, who's a professor at Barcelona and has a very long biography, which we'll take up most of the time if we go through it. So she'll be talking to us in a bit about some summary comments and so forth. We have some great speakers. There is a change on the schedule in the sense that we don't think Dr. Anna Carolina Santelli is joining us, unfortunately, as we haven't heard from her. So we are going to have two speakers. I will give a few introductory comments, and Clara will sum up with some key issues. So let me just set the stage. Okay, there we go. So if you haven't been paying attention at this conference, you may have heard that there's been some progress in reduction of malaria over the last decade or so. That certainly is a common theme at almost every presentation. And that's evident by massive decreases in both prevalence and incidence. These declines have implications in terms of pregnant women, of course, and we've seen some recent data from Clara's group in particular showing how this improved malaria control has resulted in reductions in levels of immunity among pregnant women who then present with increased parasite densities and increased adverse effects due to their malaria in pregnancy. So it's good to recall that this is it's a good thing that we're having less malaria, but it does affect pregnant women even more so. So what do I point maybe that way. Okay. So along with these effects on pregnant women, of course, countries are interested in moving to the next stage, moving towards pre-elimination and, in some cases, elimination and setting goals. And so, of course, to achieve those goals, you need to have very high coverage with your core interventions, case management, surveillance, vector control, and so forth. And countries are exploring, as you've no doubt also heard during this week, various incarnations of using mass drug administration, targeted mass drug administration to further reduce transmission. So I've summarized here on this slide these are not all of the WHO recommendations related to MDA, but these are some of the ones that are key. MDA can be considered for use by programs in areas approaching interruption, so very low transmission areas, as a component of accelerated elimination in the greater Mekong due to artemisinin resistance, in the context of epidemic control, and then in areas where health systems may be overwhelmed by situations, and you'll hear a little bit about that from Dr. Smith. And then another recommendation, of course, is that medicines used must be effective, and these days that essentially means ACTs. So what is it? What is the treatment guidelines with regard to ACTs and pregnancy? Well, ACTs are approved for use in the second and third trimester of pregnancy, and that has been the case for quite some time. But to the present day, ACTs are not indicated or approved or recommended for first trimester pregnancies unless there's absolutely no other therapy available, or that there is a severe disease, so you would need intravenous artesunate. Quinine and clindamycin is the recommended regimen, even though, and we could get into a long discussion on that, there are clear problems with that regimen as well. So what is it that is the issue around ACTs in the first trimester of pregnancy? Well, there are animal models that show definite embryo toxicity when the animals are exposed in early pregnancy, resulting in teratogenicity. And in humans, the equivalent sensitive exposure period is around 6 to 12 weeks of gestation, so smack in the middle of the first trimester. And of course, in the context of MDA, then you would have a number of women who might be in early pregnancy, who might not be aware of their pregnancy, and who would then have inadvertent exposure to artemisinin. So what exactly do we know about this risk, which is based largely now on animal data? So these are data from Stephanie Delacour. Many of you in the room may know Stephanie, who has pulled together all the available data on early exposure in pregnancy to artemisinins. These are studies involving about 30,000 women in 7 countries, both in Africa and Asia, Southeast Asia. Amongst all of those, there are 717 first trimesters pregnancy exposures to artemisinins and another 947 to quinine. And these are well-documented exposures both by history and by review of antenatal records. And I think the bottom line here is that the available data that we have suggest that when you look at these exposures and you restrict as well as you can to the embryo sensitive period, or even more broadly in the first trimester, there is no difference in risk amongst women exposed to artemisinins compared to those who received quinine in terms of miscarriage, stillbirth, or congenital malformations, although understandably there are very few cases in the congenital malformation category. So this is data that's been submitted for publication. Once it's reached that point, when it's published, WHO will consider these data in the context of the chemotherapy technical expert group and for consideration of the policy revision on first trimester use of artemisinins. So how is this approached in terms of some of the issues around MDA? Well, about 2% of the general population is likely to be pregnant at any given point in time. And what can you do about determining pregnancy status in women in the context of an MDA? Well, you can ask, you can test, or you can exclude. In terms of asking history, it's probably the approach that's been used the most often because it's the most practical and operational, but it is potentially not necessarily perfect. And there are some studies there you see where more than a quarter of a women in a study in Africa were unable to accurately, no, that's actually just pregnant women in general. That was, they were unable to accurately recollect their LMP. And in Ghana, about 15% of pregnant women were given MDA inadvertently when the LMP was used to exclude pregnant women. So it's clearly not a perfect method. It may be the only programmatically feasible one at the current time, although some programs are using testing. If you want to exclude pregnant women, women of reproductive age, then you really remove a large part of the population for potential inclusion in MDA programs, which would, of course, reduce your coverage considerably and then have implications for the effectiveness of your intervention. So today we're going to hear from a couple of folks who have experience in this area, and I have here that we're going to hear from Mozambique, Sierra Leone, Brazil, and the Dominican Republic. That was based on earlier data that suggested that we were going to have 4 presentations, so you can ignore Brazil. Well, don't ignore them in reality, but you can ignore them for this presentation, and we're going to focus